My patient is a 61-year-old female, resident of Alwar, presented with chief complaints of pain abdomen for 4 months, yellowish discoloration of eyes and for 1 month. Patient came with complaints of pain in the epigastrium and right hypochondrium for 4 months, insidious in onset, gradual progressive, mild to moderate in intensity, continuous dull aching type of pain, radiating to back, no change with posture, aggravated on taking food and relieved with oral medication initially and needs occasional IV medication currently. Patient noticed discoloration of eyes and high colored urine since 1 month, insidious in onset, progressive in nature, no waxing and waning, not preceded by prodromal symptoms associated with pruritus generalized, moreover trunk and extremities. Present throughout the day, disturbing sleep and lifestyle. It is associated with acolic stools and no history of melena initially. Patient also complains of vomiting occasionally since 15 days, non-bilious and non-projectile, 1 to 2 episodes in a week, small quantity, 10 minutes after consuming food, contains food particles, no postprandial fullness. History of weight loss of 15 kg in 4 months present and history of loss of appetite is also present. With the above complaints, patient visited the hospital where she underwent some radiological investigation and an endoscopic procedure 20 days ago, following which the patient had improvement in jaundice and pruritus. For the past 7 days, patient is having melena. There is no history of fever with chills or rigors, no history of recurrent episodes of right hypochondriac or epigastric or pain in the past or jaundice episodes in the past, no history of hematemesis, easy fatigability, no history of abdominal distension, respiratory discomfort or chest pain, no history of headache, blackout or seizures, no history of back pain or bony pain. Past history, patient is a known case of meltus and hypertension, not on regular medication, no other medical risk factors. Patient has underwent hysterectomy 20 years back. Personal history, patient consumes vegetarian diet, sleep is disturbed, appetite is decreased, regular bowel and bladder habits, no history of alcohol consumption or smoking. Family history, nothing contributory. Summary, 61-year-old female, known case of type 2 diabetes mellitus and hypertension, not on regular medication, with history of painful progressive jaundice, with ecolic stools and intractable pruritus, and significant loss of weight and appetite. Has undergone ERCP stenting 20 days ago with partial resolution of symptoms.
I think in between you missed the treatment history here, of course, you have mentioned. Yes.
Yes, sir. I had told in the history of presenting illness, so I omitted, sir. Shall I mention again, sir?
No, it's okay. So come to go back to the first slide, first the presenting complaints. It is always better to mention which part of the abdomen the patient is complaining of pain.
Okay, sir.
Because then it becomes easier for you as well as examiner to localize the thought process to that quadrant. So you could say that pain in the right upper quadrant of the abdomen or pain in the upper abdomen, whatever the patient has said, for 4 months. Okay?
Okay, sir.
I think your history is quite detailed. So let's go to the summary directly. So what in the summary, you have missed one important point in the history. There was one more symptom, or maybe 2 more symptoms.
Vomiting was there, sir.
Yes. Don't you think it is significant?
The vomiting history is not typical of gastric outlet obstruction in this patient. It is more of gastritis or related to jaundice itself.
Jaundice would not cause vomiting.
I mean, malignant gastroparesis like picture.
Yeah. So that is not jaundice. That is malignancy.
Yes.
Jaundice itself will not cause vomiting. Jaundice can cause severe anorexia, whether it is medical jaundice, viral hepatitis, whether it is benign obstructive jaundice, say of CVD stone. It can cause anorexia, but it doesn't cause vomiting. Vomiting may be there in the prodromal phase of hepatitis, maybe. But yes, malignant gastroparesis. But then malignant gastroparesis, the picture is same as gastric outlet obstruction.
Audio is not.
So what I was saying, that jaundice itself will not cause vomiting.
Yes, sir.
Jaundice can cause anorexia. Even medical jaundice can cause anorexia, but it will not cause vomiting. That is one. And yes, malignant gastroparesis can be there. But then malignant gastroparesis, the clinical picture is same as gastric outlet obstruction. It is only when you investigate and you do not demonstrate mechanical obstruction that you label it as malignant gastroparesis.
Okay.
So even if you are going to say later that it is not important, but in the summary, all presenting complaints should be mentioned, and similarly, the history of melena also should come.
Okay, sir.
Because as we will discuss, these are important symptoms which hint towards the possible site of obstruction or malignancy in any case. So with this history, what is your interpretation?
It's a surgical obstructive jaundice, sir. Malignant more than benign. And my differential diagnoses are first is carcinoma gallbladder, carcinoma head of pancreas, periampullary carcinoma, hilar cholangiocarcinoma in that order. And I still want to keep choledocholithiasis, which I want to rule out, even though it is
15 kg weight loss in 4 months. Very, very unlikely.
Yes,
very.
Yes.
So I don't think these are possibilities. But when you say differential diagnosis in this particular case, I don't think you would. You should consider choledocholithiasis. That would not. It would be virtually impossible for you to explain 15 kg weight loss with choledocholithiasis, and then pain has been continuous for last 4 months.
Yes,
jaundice has come much later. In choledocholithiasis, pain and jaundice would usually occur together, unless you say that the previous pain is gallstone pain and now the jaundice is because of kidney stone, but then that pain should be like biliary colic. This is a continuous pain which she is having for last 4 months. So I don't think in this particular case you should put choledocholithiasis as a differential diagnosis.
Okay.
May I interrupt, sir?
Yes, Rajin.
Yeah. It's very important to elaborate on the vomiting. You have to tell what is the nature of the vomit, how far it is falling, is it projectile, is it sour tasting, is it neutral tasting, or is it bitter? Because all these can have an implication as to the location of the obstruction. If it's bitter and if it's yellow, then you can think of third and third part obstruction.
दो ही मिलाए थे
4 पे 2
दो चम्मच उसकी थी
तो हाँ
प्रोटीन की
वो उसके बाद प्रोटीन पाउडर नहीं दिया मैंने खुद दो डाला था ना वो
Somebody, your mic is on, please mute your...
नहीं था वो खीर सी थी क्या थी
Yeah, Krishna, please respond to Dr. Desai's question.
Yes, sir. The vomiting was non-projectile and non-bilious, sir, in this case.
Was it containing food particles? Was it pre-digested food particles?
It was containing food particle. It was small in quantity and it occurred the episodes were 1 to 2 per week, sir. It was not present daily.
What was the relation to pain? What was the relation to...
It was not related to pain, sir, but occurred around 10 minutes after the food intake.
Yeah, this is important because it could be a reflexive pain from a peptic ulcer disease. You have had hematemesis. There is a history of vomiting, which is not bilious. There is reflexive vomiting. Immediately after food, she is vomiting once or twice. You can't rule out a gastric ulcer under these circumstances. And I will say the surgical obstructive jaundice is because of nodes in the porta.
Okay, sir.
You can explain it with carcinoma stomach.
Hematemesis was not there in this patient, and patient complains of melena, that too recently after some endoscopic intervention, sir.
Yeah. So how do you, why do you say it is carcinoma of gallbladder?
First thing, sir, elderly female of North Indian resident, and the pain preceded jaundice, sir. In this patient, the pain was present for 4 months and recent development of jaundice. And there is loss of weight and loss of appetite, and the patient and it is painful progressive jaundice, sir. And there is a
site of pain also. You should say that if the pain is in the right hypochondrium, it is more likely to be gallbladder. If it is in the epigastrium, it is more likely to be head of the pancreas. The pain of head of the pancreas malignancy would be typically in the mid-upper abdomen with radiation to back and a relationship with posture.
Yes, sir.
So, as we have discussed so many times earlier, if you have pain and jaundice, these are the two possibilities. Periampullary and hilar cholangiocarcinoma are less likely because both those conditions have usually painless progressive jaundice. In some patients with periampullary carcinoma, you can have pain of the distended gallbladder because the gallbladder gets usually distended. It may cause visceral pain, but usually it is painless progressive jaundice. So what does, suppose we say that this vomiting is the early phase of gastric outlet obstruction, how does it help you in making a diagnosis out of all these four possibilities?
Then it points more towards carcinoma head of pancreas, sir, rather
Yes.
than a gallbladder.
So gastric outlet obstruction amongst these four possibilities, and the last is, as Dr. Rajen Desai pointed out, that if you have a non-pancreaticobiliary malignancy with nodes in the porta hepatis or hepatoduodenal ligament which are compressing on CBD, that can also cause obstructive jaundice. So if you have gastric outlet obstruction, then carcinoma head pancreas becomes the strongest possibility, followed by carcinoma gallbladder. Periampullary and hilar cholangiocarcinomas will not cause gastric outlet obstruction because the tumors are usually small.
Yes.
Now, how do you interpret the melena in this case?
Patient had recent development of melena after endoscopic procedure. Maybe they have put ERCP stenting, and sphincterotomy can cause bleeding, which can cause melena in this patient.
That you could have easily made out by making a chronological relationship between the procedure and the onset of melena. If it happened immediately after the intervention, then it could, yes, possibly be related. But if there is, suppose after the intervention, the patient passed normal stools and then the melena happened, or if the melena happened before the intervention, then obviously it is not related. So if you are giving that interpretation, you should have given us more information about the timing of the intervention and the timing of onset of melena.
Okay. Actually, there is a period of normal stools, sir, in between. So it can be due to tumor slough off also.
Yeah, so that is important. So suppose I say it is not related to the intervention. Suppose it was there even before the intervention or it happened after a couple of days after the intervention. Then how do you interpret melena?
Then it can be due to the tumor sloughing off.
So which tumor you are talking about?
Periampullary tumor, sir. In that case.
So in a patient with malignant surgical obstructive jaundice, if you have GI bleed in the form of melena, what is the most likely possibility?
Periampullary carcinomas.
No, it is CA head pancreas which is infiltrating the duodenum. Periampullary carcinoma causing this sloughing and some melena, those silver-colored stools and temporary relief of jaundice is more theoretically described in textbooks rather than seen in clinical practice. In malignant surgical obstructive jaundice, if you have melena, it is more likely or the higher possibilities that it is CA head pancreas infiltrating duodenum or CA gallbladder infiltrating the duodenum.
Okay.
Periampullary carcinoma presenting as melena and temporary relief of jaundice is not a very common situation, although it is mentioned in all textbooks. But in real life clinical practice, it's not a very frequent observation. So that is why I said that vomiting and melena to me point more towards a CA head pancreas rather than CA gallbladder. So I would probably put CA head pancreas as the first diagnosis because again in CA head pancreas, the patient can start with pain and then develop jaundice, followed by carcinoma gallbladder. Periampullary and hilar are very, very unlikely. And choledocholithiasis, as I said, probably you should not mention. Okay?
Okay, sir.
Let's proceed. Rajendra, anything you want to add?
General physical examination. My patient is an elderly lady, averagely built and well nourished, with a BMI of 25.6, ECOG status of 2. She is conscious, cooperative, well oriented to time, place, and person, lying comfortably in bed, with a pulse rate of 80 beats per minute, blood pressure of 116 by 70 millimeter of mercury, respiratory rate of 16 cycles per minute, and saturation of 98 to 99% at room air. Patient is hydrated, icterus is present. Scratch.
Sorry, there is a contradiction because first you said she has lost 15 kg and now you are saying she is well nourished. Is that information correct that she has lost 15 kg? Was it a measured weight loss?
Yes, sir. It was a measured weight loss. Even with that, the patient is obese, sir, right now. She might be still more obese at that point. She has lost weight. Icterus is present. Scratch marks noted over trunks and flexors aspect of extremities. There is no pallor, cyanosis, clubbing, left supraclavicular lymphadenopathy or pedal edema. There are no peripheral signs of CLD.
Go back. So I know all of you follow this pixel kind of thing for general physical examination, but from surgical point of view, more important are pallor, pedal edema, lymph nodes. Cyanosis and clubbing for surgical patients is not of much importance. So some examiners may kind of stop you there and ask, why did you mention cyanosis? It is always better to mention more important negative findings first and then mention the others.
Examination of abdomen. Abdomen is protuberant. Umbilicus is central in position and inverted. All quadrants move equally during respiration. Phenensteel scar healed by primary intention noted. No mass, sinus, engorged veins, pulsation or peristalsis seen. Hernial sites appear normal. No renal angle fullness. External genitalia appear normal.
What is Phenensteel scar?
Lower suprapubic transverse scar, sir.
So if there is a suprapubic transverse scar, does it necessary? What is Phenensteel? What is Phenensteel?
It's the name
of
surgeon mostly, sir. I don't
name of a physical finding. Name of what? It is the name of an incision.
Yes, sir.
So can you describe what is Phenensteel incision?
It's a suprapubic incision 2 centimeter above the pubic symphysis. It's a transverse incision, which is mainly used in gynecological procedures.
So you keep on dividing in the same line?
The incision, sir.
No. So you divide everything in the same line, 2 centimeter above the pubic symphysis transverse?
And muscles are not divided usually. It is split, sir.
So that is what the skin incision is transverse.
Yes, sir.
But the sheath incision is vertical. So from physical examination, how can you say what was divided inside? You should only say there is a suprapubic transverse scar. Phenensteel is the name of an incision. It is not the name of a scar. Scar does not necessarily tell you what is the incision inside. Scar only tells you what is the skin incision. That is what I tried to tell you. Phenensteel is a typical incision where skin and subcutaneous tissue are divided transversely, but the sheath is divided vertically, so that the muscles are not divided. That you can't say from looking at the scar.
On palpation, abdomen is soft, no local rise of temperature, non-tender, gallbladder is palpable, no hepatosplenomegaly, hernial orifices are normal, external genitalia is normal. Liver dullness starts at 15th intercostal space.
Go back. Is it enough to say gallbladder is palpable? That's all?
A globular pear-shaped structure is palpable in the right hypochondriac region, which is firm in consistency. All borders are well made out except for the upper margin, with side-to-side mobility and movement with respiration. Most probably is a gallbladder.
Your examination is grossly incomplete. If something is palpable, you have to describe it in more detail. And as I have said so many times earlier, for me, it is okay if you say gallbladder is palpable, but some examiners, they still insist that you describe the findings and then give your interpretation. So you should say that the lump is palpable in the right hypochondrium. It is globular, lobular, oval or pear shape. This is the size, vertical. This is the size, horizontal. Does it move with respiration? Does it have intrinsic mobility? Is the surface smooth? Is it soft, firm or hard? So you can't just say gallbladder is palpable. Describe it again.
A pear-shaped mass in the right hypochondriac region, 5 into 3 centimeter of size. All borders are well made out except for the upper border. It moves with respiration and there is side-to-side mobility. The surface is smooth, firm in consistency. The plane of the swelling is intraperitoneal and intra-abdominal and intraperitoneal. And it is present 8 centimeter lateral to the midline.
So that should have come in the first instance. So what do you think it is?
It is a palpable gallbladder, sir.
And also when you palpate something, you should not say mass, you should say lump.
Okay.
Lump, then you interpret whether it is a mass, whether it is a cyst, or whether it is a deposit. For example, a large peritoneal or omental deposit in a thin-built patient with lax muscles can be palpable. So what is palpable is a lump, and then you interpret it as a cyst or a mass or something else, or a normal organ. And then you should say that this looks more like a distended gallbladder. Whenever you have a palpable gallbladder, it could be a distended gallbladder or it could be a GB mass.
Okay, sir.
So what does a distended gallbladder mean in terms of your differential diagnosis?
A distended gallbladder means there is a distal obstruction to the insertion of cystic duct.
That's all.
And it is not due to a gallstone disease.
Nothing else can cause a distended gallbladder. It has to be a distal CVD obstruction.
Or else GB neck mass can also cause distended gallbladder.
According to Courvoisier's law, in a patient with surgical obstructive jaundice, if the GB is distended and palpable, it is unlikely to be CBD stones. That is what he said.
Yes.
And what he did not say, but what it also means is that most likely the obstruction is at the lower end of CBD, usually due to malignancy. But we know that it could be due to a mid-CBD block also, like a mid-CBD cholangiocarcinoma. It could be due to a cystic duct block also, like in GBC neck. And an exception is that there is a stone in the CBD and there is a stone in the cystic duct. So the stone in CBD is causing jaundice and stone in the cystic duct is causing a distended gallbladder. So these are exceptions. Last time some students said Miridzi, but Miridzi usually does not cause distended gallbladder because Miridzi is a manifestation of long-standing chronic cholecystitis where gallbladder is usually thickened, contracted, shortened, and not palpable. Okay, next.
Liver dullness starts at 5th intercostal space in the right midclavicular line. Liver span is 13 centimeter. A dull note over the gallbladder is continuous with liver dullness. The rest of the abdomen is tympanic. Auscultation, normal bowel sounds are heard. Per rectal examination, sphincter tone normal. No Blummer shelf nodule felt anteriorly. Mucosa is normal. Yellowish fecal staining of finger present.
Did you do a proctoscopy?
No, sir.
Then how can you say mucosa is normal?
Felt normal, sir.
So you should say that there is no nodularity on the mucosa. Without inspecting, you can't say that mucosa is normal. You can only say that there is no nodularity or lump palpable in the mucosa. Because in per rectal examination, usually we do the palpation first by finger and then we do the inspection by proctoscopy. It is the reverse order.
Examination of a respiratory system, bilateral air entry is equal, normal vesicular breath sounds present, no added sounds. Examination of CVS and CNS is essentially normal. Summary, 61-year-old female with ECOG status of 2, known case of type 2 diabetes mellitus and hypertension, not on regular medication, with history of painful progressive jaundice with echolic stools and intractable pruritus, with significant loss of weight and appetite, with recent development of vomiting and melena, has undergone ERCP stenting 20 days ago with partial resolution of symptoms. On examination, she is ectric with scratch marks and a distended gallbladder, distended palpable gallbladder on examination.
Yeah, in the summary, you should also add no clinical evidence of dissemination.
Metastasis. Okay.
And we didn't discuss this, that how does this treatment history help you in making a diagnosis?
Patient has underwent ERCP and stenting with partial resolution of symptoms, sir. It most probably points towards distal obstruction rather than proximal obstruction.
Why in proximal obstruction you cannot have relief of symptoms with stenting?
We can have, sir, but in cases of more proximal obstruction like hilar blocks, the success of stenting is less, and then the post stenting patient might develop signs of cholangitis also, if partial drainage of liver is done.
So it is the other way around. If the patient has got relief with endoscopic intervention, it doesn't tell you, because suppose uh, the endoscopist was an expert, he or she has been able to put a stent even in a high obstruction patient, will have relief of symptoms. If the endoscopic intervention fails, then you can say that it is more likely to be high obstruction, because lower end obstruction, unless there are anatomical or technical reasons, stenting should not fail, should not be unsuccessful, or should not cause no relief of symptoms. So it is the other way around. It doesn't actually help, because in CAGB also, or in cholangiocarcinoma, good endoscopists can place a stent and patient can have relief. You don't know whether one stent was placed or two stents was placed. Even if biliary ductal confluence is present, he could have placed stents on both sides. Even placing stent on one side in a patient with hilar or confluence block, you can have relief of symptoms. Okay. Yes. So does the examination change your differential diagnosis? What is your differential diagnosis now?
I'll keep it as malignant obstructive jaundice, sir. Even after stenting, the GB is palpable, sir, with partial relief of symptoms. So I want to keep carcinoma neck of gallbladder as my first probability, sir.
Yeah, but with a distended gallbladder, you cannot keep a possibility of a hilar cholangiocarcinoma. Now you cannot say that this can be hilar cholangiocarcinoma. Hilar, if the gallbladder is distended, it is not hilar cholangiocarcinoma. It is as simple as that. Unless, theoretically speaking, you can say that it is a hilar cholangiocarcinoma which has come down and it has blocked the cystic duct, and now what I am palpating is a mucocele of gallbladder. So theoretically, yes, but practically speaking, no. So yes, your point is very right, that even after stenting, more so because it is a successful stenting, because there is a history of relief of symptoms.
Yeah.
Which means that stent has gone beyond the obstruction and it is patent. So even with a patent stent which has relieved the biliary obstruction, if the gallbladder is still distended, still palpable, then it is unlikely to be carcinoma head pancreas or periampullary carcinoma. Because in these conditions, as soon as you place the stent, after some time, the gallbladder should decompress and it should not remain palpable. The fact that it has remained palpable means that the CBD is also obstructed and cystic duct is also obstructed, which means it is carcinoma gallbladder, neck, or a mid-CBD cholangiocarcinoma. Both are possible. But statistically speaking, carcinoma gallbladder neck is much more common than mid-CBD cholangiocarcinoma.
Yes.
But you should not say hilar cholangiocarcinoma here. Okay, what will you do?
In this patient, I want to review the previous investigation, sir. Blood investigation. I want to look at the hemoglobin total counts.
You have the previous investigations. Let's see.
Yes, sir. This was the previous investigation pre-stenting, sir.
Yes.
There is anemia present, and increased counts are increased. The bilirubin levels, it shows obstructive jaundice pattern, sir, with mildly increased enzymes. Alkaline phosphatase is very much increased, more than 1.5 times increased. Albumin status is fine, sir, 3.6, towards the lower end of the normal. PTINR synthetic function is normal. And serum creat is 0.4 and urea is 23. It is towards the lower side. Maybe patient is having cachexia, serum creatinine is towards the lower side, sir. And patient is a known case of diabetes. Sugars are bit towards higher side with HbA1c maintained levels. And CA99, it is more than 1000, sir. Even though there is biliary obstruction, it should not be, it should be done after draining, after the bilirubin levels are normal. More than 1000 is a very high value, sir, which is pointing towards malignancy. So this patient is in cholangitis, sir.
Subclinical cholangitis.
Yes, sir. Next, USG report was not there, sir, pre-stenting, but CT report was there. CT video is there.
Let's see.
This is CT scan of lower chest and abdomen, sir, non-contrast phase. There is no pleural effusion present. The liver surface appears regular, sir. There is prominent biliovascular markings present. Gallbladder is distended. No mass can be appreciated in this phase.
You should not comment on the presence or absence of a mass on a plain phase. Only thing you should comment is that there is no calcification seen. Either in the gallbladder wall or any calcified stones or in the head of the pancreas, because you are thinking of, not now, but earlier you were thinking of chronic malignancy of head. So whether it is malignancy superimposed on an asymptomatic chronic pancreatitis, so that is what you should see in a plain CT.
Okay. And no ascites is present. Next, I want to look at the contrast phase, sir. This is contrast enhanced CT, portal venous phase. No pleural effusion is there. Liver, the surface appears regular. There is intrahepatic biliary radical dilatation present. There is a mass at the hilum, sir. I want to trace the intrahepatic primary and secondary confluence of the bile duct. As we can see here, the secondary confluence is forming and the left duct can be appreciated at this point. As we, at this point, we can see the left duct. Here, we can see right anterior duct joining the left duct. And as we come down, this is the right posterior duct, sir. At this point, there is a narrowing of the CHD with a mass-like lesion with enhanced wall, sir. As we go down, this is the CBD with narrowed extrahepatic bile duct with enhancing wall, which is encased in the mass here. As we trace down, there is a long segment involvement. Here, the lumen can be made in the extrahepatic bile duct, but the wall enhancement is still there. And just beside this, the GBS started appearing, and at this point, this is looking like cystic duct, sir. As we trace down, the intrapancreatic part of CBD is fine. At this point, the extrahepatic biliary apparatus thickness is present till the suprapancreatic region, sir. And as we trace, this is the cystic duct origin from the neck of the gallbladder, and here this is the cystic duct. It is also encased in the mass, sir. So it is looking more like a mid CBD or hilar mass involving the cystic duct. Next, I want to look at the relationship with the surrounding structures.
Yeah, so in whatever you have described and whatever we could see, it looks more like a mid CBD cholangiocarcinoma, which is obstructing the cystic duct, and it has gone up to the confluence. The confluence doesn't seem to be normal, if what you said was right, that probably the right posterior is joining after the right anterior and left have joined. And that is the reason why, as we will discuss later, in a patient like this, you need a cholangiogram to delineate the biliary ductal anatomy and the extent of biliary ductal involvement. In a mid-CBD cholangiocarcinoma, it is also very important to see whether the intrapancreatic part of the CBD is involved or not, because that is what would decide whether a PD will be required along with the CBD excision, and the proximal extent will decide whether a hepatectomy will be required. It is such cases where the Japanese centers and Japanese surgeons have described HPD. HPD for CHGP, they don't do now, they have almost stopped doing, but HPD for a cholangiocarcinoma, which is extending both up and down, involving the confluence and involving the intrapancreatic part, is still being performed by them. Yes.
Next, I want to look at the surrounding structure, sir, relationship. First, I want to see the portal vein. The portal vein looks involved at the origin, sir.
Show the origin. Veins don't have origin. Veins have where it is formed.
Yes, sir. Sorry. So at this point, splenic vein is joining the SMV at this point, and formation of portal vein is there. There is a narrowing at this point. So as we trace above, the right and left are dividing at this point, and it is normal here. As we go back, there is complete narrowing and change in the contour of the portal vein, sir, at the level of formation.
Go down. That's the formation. Go up, go up.
Yes, sir.
This is the formation.
This is the SMV. Yes, sir.
Yeah, this is the SMV. Go up.
And this is the,
this is the formation. Here it is normal. Now go up slowly. Even here it looks normal. Now it is chinked.
Yes.
So you see a normal size up and normal size below, but in between the size is small, or there is alteration of shape, or there is complete obliteration that indicates. So it is involved, but not at the origin.
Yes, sir.
Because origin, as you know, lies behind the neck of the pancreas.
Yes.
It is very unlikely that a cholangiocarcinoma will cause narrowing or alteration of shape or distortion of the portal vein at its origin. So do you appreciate that? Go back again where it is forming. Where it,
this is the SMV.
This is the SMV. Go up slowly.
And here the portal splenic vein is joined.
So here it is normal. Maybe one or two cuts more, it is normal. Up.
Yes, sir.
Yeah. Here also it looks normal. But just beyond that, it becomes abnormal. So it is at the almost at the upper border of the pancreas that the tumor is involving the portal vein, and that is why you have to be very careful whether. Just give me a minute. Hello. Yes, 11 o'clock. 11 o'clock. Yes, sir. In general surgery seminar room, I will be there. Definitely. I'll join you. Yes. Sorry. Yes. Okay. So portal vein is involved, no doubt, but not at the formation. It is in the
suprapancreatic.
Yes.
Superior. The intrapancreatic part of CBD is looking normal, sir, and MPD is not dilated. And the superior border of the pancreas also looks fine, sir. And then I want to look at the arterial phase to know the relationship of tumor with the hepatic CH and right hepatic artery, sir. And
so does the involvement of the portal vein make it unresectable?
Main portal vein has a clearly it is not unresectable, sir. If you can reconstruct the portal vein with giving a R0 resection, still we can go ahead with surgery.
So the theoretical answer is that involvement of the portal vein, and some groups would, those who are very aggressive, say that involvement of even the proper hepatic artery does not make a cholangiocarcinoma unresectable. Gallbladder cancer, yes. That is the difference because of the difference in biology. So cholangiocarcinoma vascular involvement is not a contraindication for resection, provided you have the expertise to resect and reconstruct the vessels. Gallbladder cancer, involvement of main portal vein and proper hepatic artery, most groups today will say it is unresectable. Right portal vein, right hepatic artery is not unresectable because you can do a right hepatic.
Next, in this phase, I want to look at the any lesion in the liver, which we didn't see. There is a small cystic lesion in the left lobe, sir, which is looking like a simple cyst.
Since we don't have much time, do we have a cholangiogram in this case?
No, sir.
MR was not done.
MR is not done, sir.
Do we have any information from the ERCP which was done
Yes,
about
sir.
the extent of involvement?
Yes, sir.
Anything else on CT important in the report?
No, sir. Lymph nodes also. There is a HDL lymph node, sir. Prominent, multiple HDL lymph nodes are there. Interaortic cavern lymph nodes are not there, sir. And this was the ERCP report, sir. The contrast cholangiogram showed a mid CVD stricture of around 3 centimeter length, sir, in this.
No, but did they comment on whether the confluence is patent or not?
No, sir. That they have not.
They should have. Although, ideally, when you have a biliary obstruction, most endoscopists would be reluctant to inject large amount of contrast because that is not the purpose. Some people would not even inject any contrast. They would just drain. And some people would use air to obtain a cholangiogram, an air cholangiogram. So that is why it is important that in all these cases, GBC, neck, hilar cholangiocarcinoma, mid-CVD cholangiocarcinoma, you want a proper cholangiogram, which would be an MR cholangiogram, because we want to see the proximal extent of the tumor, and also we want to see the distal extent. Distal extent may be difficult because MRCP shows the ducts only when they are filled with fluid. If there is a mid-CVD block, the distal duct may not be filled with fluid. So that is why when you do a resection in these cases, you have to send both margins, both proximal and distal margin for frozen. And if the margin is positive, then you may have to add a PD or you may have to add a hepatectomy. Anything else in this case?
No, sir. Post stenting, the bilirubin levels have come down. 4 to 2 total bilirubin, and the cholangitis has settled, sir. There is no increased TLC, and enzymes have also decreasing trend. Albumin has decreased significantly, sir. It is 2.8 now.
Yeah, so that usually happens. These patients are chronically dehydrated and their serum albumin and hemoglobin levels are falsely high. Once they are admitted in the hospital, especially for a procedure, they are looked after well, they are properly hydrated, and this is probably the true reflection of the serum albumin.
Yes.
And you were showing some FNAC report or something?
Yes, sir. Brush cytology they have taken, which shows atypical cells suggestive of malignancy.
Yeah, so the other question which is often asked is that, is it important to have a tissue diagnosis? How do you get it? So if you want to continue discussing this case, please let Dr. Anand know. He will slot you again. We will continue the discussion of further investigation and management of this case. I have to go for an academic meeting after this. But I think we should continue to discuss the management of resectable as well as unresectable mid-CVD cholangiocarcinoma. Okay?
Okay, sir.
Thank you.
Thank you, sir.